but I have great affection for and respect for these small systems, and in some ways, I've really learned that there are advantages to being small. It forces you to work as a team and to talk to each other, and at times, I think that's one of the things that's missing in overall healthcare. So anyway, that's where I'm coming from.
Well, we sure appreciate it. Kevin, if you would like to share some ideas and thoughts with us, that would be fabulous.
Thank you, Senator. I want to tell everyone a little bit about my hospital. The building behind me that you can see on the screen was built right after World War II when the veterans came back from the war and they wanted to have a hospital built. So they just built it. They didn't hire an architect. They didn't ask permission from the state. They just built the hospital, and that's the building that we operate in today. I'm the only hospital on the I-70 border between Denver and Burlington, which sits close to the Kansas line, and that's a stretch of about 180 miles. So I always tell policymakers in Denver or DC, you care about my hospital if you've ever driven on I-70 east of Denver, because we're the only emergency care that's out there. More importantly, we serve an area roughly the size of the state of Connecticut. And in that area, though, we only have about 2 people per square mile. So as Dr. Dean was talking about, we're an independent community hospital that is focused on preventive care and primary care and taking care of the good folks that live out in our area, and then making sure that folks who travel through our area are appropriately cared for in the event that they need to see an emergency department. Rural health is so important. It's so essential to the communities that we serve. Not only do we offer health care, I'm the second largest employer in the county. So we're a real economic engine. It's very difficult to recruit teachers or any kind of business whatsoever if you don't have healthcare and reliable healthcare available in the area. So we have a lot to talk about today, but that's the world in which I live, and I'm proud to represent Lincoln Health and other rural hospitals across the country.
Thank you. Jean?
Thank you so much for inviting me. My name is Jean Lambrou. I am coming to you from Maine, where I mostly grew up. I studied here, learned here, but went to graduate school and learned about health policy, public health, went to DC to work on health reform, and came back to Maine about 6 years ago to work on running the Maine Department of Health and Human Services. And in every one of those capacities, I felt as though what we see in rural healthcare is both the best and the canary in the coal mine. The best being how communities come together to serve each other, to serve the population's health, to serve the state's health, because we know it's an economic as well as a personal issue for people to have good health care. I also know that the places in rural areas in this country are the ones that feel the change that's coming quickest. You know, the reimbursement changes that affect our hospitals nationwide affect our rural hospitals first. The challenges of workforce that we have experienced many times over the decades are often first felt in our rural areas. And the need to find innovation and ideas for connecting people to quality, affordable healthcare often originate from rural areas. So I'm thrilled to be part of this panel, and thank you very much for inviting me.
Well, thank you to all of you. And, you know, just this past week, we saw legislation passed in one of the areas that is going to be affected the most is rural health. That there's concern with the area of Medicaid that we could lose up to 10 million insured in my home state of Indiana. That would translate to about somewhere in the neighborhood of 200,000 of our local citizens who lose health care. And when they lose health care, it again comes down to, so they're still going to need care. and Kevin, they're still going to need to come to the hospital, and they're still going to need to be treated. And how do you get reimbursed, I guess, is another question. So I'll ask you, Kevin, first. What's the future like when you look at it?
It's pretty scary. And you hit the nail on the head, Senator. We're taking away access to healthcare for people, and oftentimes that access gets them in to see the primary care physician like Dr. Dean, allows them to have their chronic disease managed appropriately, allows them to take part in preventive care to keep them healthy. And what we experience and it happens sometimes where somebody lapses off of Medicaid or is uninsured, they allow chronic conditions to deteriorate, they get sicker, they end up in our emergency department, which is the most expensive level of care. And we take care of them because we take all comers. That's part of our mission. But it's also the law, and TALA requires hospitals to care for anyone who presents to their emergency department in an emergency medical condition, to care for them regardless of their ability to pay. I have no quarrel with that law whatsoever. I think that's right and just. But what we can't take away that patient's ability to get access to care to prevent them to coming from the emergency room. And it seems to me to be a reasonable investment to invest in primary care and preventive care and chronic disease management to keep people healthy and keep them out of the emergency department.
Yeah, when you look at the emergency room and being at your hospital, I remember I mentioned this earlier today during the discussions about the Affordable Care Act. We had a local hospital once the Affordable Care Act passed, where they saw a dramatic increase in heart-related cases. And so they had one of those meetings where, okay, what's causing this? And there's 10 people around the table. It's like, is it something going on in the community, or is this or is that? And one of the folks there said, hey, I think I figured this out. These were pre-existing cases of problems.
Mm-hmm.
But before, they couldn't afford to get treatment, that they had to decide whether they were going to take care of their family and feed their family or take care of their medical condition. Now, for the first time in their life, they have care. And since they have care, they've come in to get checked, and they can finally get this taken care of. And so the question about preventative care, they can actually get care as opposed to letting it turn into some chronic situation. And the Affordable Care Act, they estimate, put about 20 million more Americans were able to get insurance. They're fearful that with this legislation, 11 million will lose that insurance. And so, Dr. Tom, what have you seen over the years in terms of chronic care and treatment, and how important insurance is for them?
Well, it's very important. Actually, I had the experience from a slightly different perspective. I was on the board of a local insurance company when the Affordable Care Act passed, and this company put out some attractive fee schedule, but they were overwhelmed by way more than anyone expected the number of people that signed up that with those pre-existing conditions that simply weren't being treated.
Right.
And so it was a wonderful thing for the patient. That particular year was not a good year for the insurance company.
Right.
But it was their mission to see that they got taken care of. So I had the good fortune of working for a community health center where we all the time took all comers, whether they had insurance or not. So I was somewhat protected from that. But there's no question that people are threatened by these costs and put things off. And as was alluded to earlier, it usually means that the conditions simply get worse and that the costs get worse and the outcomes are poorer if they put it off.
Gene, what have you seen in the rural areas of Maine in regards to healthcare over the years, how it looks moving forward, what to expect?
Yeah, it's been truly a privilege to be able to have worked at the White House during implementation of the Affordable Care Act, where we watched people, again, coming out of the woodwork seeking healthcare. You know, in those early days when we were struggling to get the website up, there were people literally putting their applications under people's doors to say, I need healthcare, help me. And then fast forward, when I came to the state of Maine to expand Medicaid under Governor Mills on her first day in office, I arrived, she directed me to expand Medicaid. The previous governor had vetoed expansion 5 times. There's a ballot initiative that implemented it. We got there. A week later, I went to a hockey rink in Maine where we were having a town hall meeting and met somebody with lung cancer who had waited for treatment to get coverage, and now that person could. We know health coverage is personal, it matters to individuals, it matters to families, but it also matters to our communities. It helps us have our children grow and learn. It helps our workers be productive. It helps our hospitals and physicians and providers and clinics stay open. So we know it's critical. So I think we're on a real cusp of having finally hit a record high level of insurance in this country, seeing a potential demise. So I hope we're all watching. And again, I think rural areas are the canary in the coal mine. They are the ones who see it first, who will feel it the most. And I am especially focused here in Maine and in my national work on how we mitigate, if not reverse, some of the changes that will be coming our way.
Kevin, one of the things that we've been hearing is we're going to lose hospitals. Tell us the economies of what's going to be factoring into that for a lot of our rural hospitals. And is it less revenue coming in, more patients? You know, how is this going to work? And what's the rub here that's going to make it so difficult?
So for us in Colorado, very much like Maine and other states, we have an expanded Medicaid state. So we've extended insurance to a number of folks. Medicaid these days is not your father's Medicaid. It actually is access to insurance that wouldn't otherwise be available. 25% of my patients are Medicaid, 50% are Medicare. We only have about 20% of commercial pay. We estimate that based on the losses, and I can get in the weeds if you like, but I'm afraid I'll put everybody to sleep.
No.
The provider taxes that they went after in this bill will likely reduce the reimbursement to my hospital by about $1.5 million a year. That may not sound a lot for larger health systems, but for me, it's devastating. We only have about 30 days cash on hand, which is not unusual for many rural hospitals. So if I lose that revenue, it puts the whole enterprise at risk. So there's a couple of things, 2 other things that I worry about. One is, I understand that because of what this bill does to the deficit, that it could trigger the PAYGO provisions, which would increase the Medicare sequestration by 4%, which will reduce my Medicare reimbursement already, which is done at just below cost. The other thing that's happening is commercial payers typically underpay rural hospitals. So when we have kind of a balance right now where we've got the supplemental payments helping us with the Medicaid, we have greater volume with those patients.
Kevin, let me just ask you real quick. So it's kind of like you figured out a balance to try to keep the doors open.
That's right. And that it's all going to be out of balance. Now we have a couple of years to try to figure out, is there a way to pull it back into balance? But somewhere there's a cost to running rural hospitals. And our fixed costs are relatively higher because I can't defray those costs through volume. So if I lose that reimbursement, that tips the whole thing out of balance and puts it at risk. And then the cash on hand, I don't have the reserves to survive, as I'm aware of other hospitals in Colorado and across the nation that have 5 to 10 days cash on. You just don't have the reserves to keep the doors open.
And the point you made at the beginning, so between Denver and the Kansas line to the east on I-70, you're it.
Yeah.
So, and it's about 180 miles.
That's correct.
And if you're not there, then what?
Right.
I mean, that's a really scary proposition at that point. What do they do?
Yeah, and that's the question. They're in rural areas, and Dr. Dean and Jean probably know this. We have a real drop off of the number of independent physicians that are practicing that can't afford to practice because of complexities of billing. So it's either the hospital or a community health center that steps in to help keep them in practice. So you're really potentially taking away access to any healthcare, not just trauma care, when you lose a hospital or a FQHC in the community.
Dr. Tom, when you look at the next 5 to 10 years, what do you think are going to be the biggest challenges, the biggest changes in rural healthcare that you see ahead?
I suppose I should make a distinction between what I see and what I hope for.
Okay. Well, we're all in for what you hope for, but I'd like to know both. Yeah.
I am concerned about the overall dysfunction in our health system in general, which is simply dysfunctional. Our costs are too high. Our vast amounts of our resources go to administration, just figuring out how to, justifying the bills that come in, and that has placed a big burden on physicians. The demands for documentation, the administrative demands. I've told a number of people that my last several years in practice were the hardest I had, not because the patients were any different. No, they were. It was the administrative requirements, the burden of documentation, and that has led so many physicians to either retire early or just be burned out and fed up with the whole thing. We have to move to an overall system that is more supportive of the providers, and I would hope that maybe we're beginning to recognize that that we've got to move in a restructuring of the overall system, but I'm not totally optimistic.
I'm going to show my age a little bit by mentioning an old TV show, Northern Exposure, which was, if you remember, it was a young doctor from New York who had his tuition partly paid for by a group in Alaska, and he wound up serving in the Alaskan bush country, unbeknownst to him when he started out. But the point of bringing enough physicians, enough nurses, enough medical personnel to rural communities, has that been a struggle?
It is a struggle, and we have an overall shortage of physicians in the country, and the number of those who are willing to look at rural practice is small, although we've been fortunate in South Dakota. Our medical school has put a huge emphasis on rural practice, and it has helped. But I think we've got to provide a supportive environment. Actually, in my own experience, one of the things that helped us a lot is we are now connected with a central, our hospital emergency room has and has had for 15 years or so, immediate telehealth communication with a referral center in Sioux Falls, which is 125 miles away, so that we have really good support when patients come in that may have problems that are too complex for us to deal with. And that has actually been a big recruiting factor, because it takes for young physicians who are used to being in big centers, this brings a lot of the support services that they're used to right to our little remote hospital.
Could you explain to the rest of us how the telehealth system would work?
Well, it has many different branches, but what's called e-emergency, which is, like I say, this is a system we've had in place for, I think, at least 15 years. A patient comes to our emergency room, and if it looks like it's something that we are going to need help with, the nurses just push a button on the wall, and we have immediate real-time video link with what's known as the hub in Sioux Falls, which is 125 miles away. And both with an emergency room physician consultant as well as nurses. And the good thing about this system is the folks that put it together understood the real needs. And when it was first put together, the guy that designed it told me, he says, you've got 2 nurses and no other staff in a hospital in the middle of the night, and the patient comes in with a big problem. Those nurses should be taking care of the patient. They shouldn't be making phone calls. And so this system, they've set up so they will call our support staff. They'll call. Actually, I got called from Sioux Falls. They told to several times, said that there was a patient in our emergency room that needed to be seen. And they would help us both with clinical evaluation, but also with logistics, and if it looked like transportation or referral was necessary, they'd help us set up. So that part has been immensely helpful and successful. We've also experienced it. Actually, I'm a cancer survivor, and the nearest oncologist is 125 miles away, but things have been pretty stable, and it's been several years since I've actually seen him in person. I see him regularly via video. So there's a lot of potential there that we have benefited from. It's only one aspect of the practice, of course, but it's been a very valuable one.
Gene, have you been using, or have you used mobile health units in Maine to go to certain communities or certain towns where folks from the area can come in if they're an underserved area?
Without a doubt, we've worked on that. Although I would just say in a state like Maine, where we have, the distance between southern Maine and northern Maine is the distance between here and DC, right? It's a big, large state. We also have weather conditions that make life flight and other transportation challenging. We have rough winters, fog, etc. So transportation has a particular challenge to it. I'll say, as the former head of the Maine Department of Health and Human Services, we have more than 24 transportation contracts to get people back and forth to services when they needed to be seen in person. So I think there's limits to how we move people. All that said, we have a couple models that we are excited about. One is mobile mental health, which has been supported by previous Congresses and previous administrations to try to move mental health services. So we have that 3 prongs of somebody in mental health crisis can call someone, see someone by going someplace, and have somebody come to them, with mobile crisis, mental health crisis. We're excited about the prospects of that and trying to build that team. We also, in rural Maine up near Moosehead Lake, have worked on how we deploy hospital and emergency medical services staff in ways that keeps them feeling fulfilled, because there's not that many emergencies oftentimes in some of these rural areas, unless it's winter with ATVs and skiers and snowmobilers, all that kind of incidental accidents. They become community paramedics and trying to work through home health visits and visits to people who are homebound and might need home checks. How do we begin to give them the training to become home health aides or other professionals so they can have dual credentials? So when they are having downtime in rural communities that need capacity for emergency or urgent care, to provide the long-term services and supports that might be needed in those years. So we're working at both directions, from urban to rural, for mobile crisis, for mental health, for example, and rural to different aspects of the healthcare system, like long-term services and supports, to ensure that we have a sustainable financing model for our rural areas.
Dr. Tom, have you been working in a like what's called the FQHC, the Federally Qualified Health Center?
Yes, that's where all of my practice was. Yes.
And could you tell us a little bit about that program? And I always found when I was serving Indiana that was a huge plus for our state, the FQHCs around the state. Could you tell us a little bit about the idea behind that and how it works?
Well, the main idea is that these clinics, our health systems, we would agree to see everyone without any regard to ability to pay, and that in exchange for that, the federal government would provide a certain amount of operating expenses for the clinic and health system. It really made my life as a physician much easier, because I didn't have to worry if this patient could afford to see me or not, because they were it wasn't totally free. There was a small charge that everyone got, but basically, and we had some arrangements where we could get reductions in pharmaceutical costs and so forth, and so that a lot of physicians have to worry about. Well, if I have this patient come back, it's just going to be one more office charge, or if I want to do some procedure or something, they won't be able to afford it. That was a worry that I never had to face, and I really appreciated that, and I know the community appreciated it as well.
Yeah, yeah. Kevin, has it been hard to be able to have all the medical professionals that you need for your location? Is there a special program that the state has to try to make sure that medical professionals go out to the rural areas of Colorado, as well as Denver and Colorado Springs and Boulder, et cetera?
Yeah, so the University of Colorado School of Medicine has a specific rural track that encourages physicians to go out and train. And then we collectively, the rural hospitals in the state, partner with most of the nursing programs to get clinical opportunities for our nurses to come out of their training in the city and come out to rural areas to experience what it's like to work in a rural hospital. One of the things that we've been working on locally with the community college system in the area is to beef up the availability of classes in the secondary schools. A couple of years ago, we did a survey there's a half a dozen school districts that we serve. None of them graduate anyone over five in a class per year. So they're very small school systems. And what we discovered was not a single one of those high schools had access to anatomy or physiology instruction. And so we've been working, as the state community college system has been working, to provide sort of the telehealth version for teleeducation, where instructors visit the schools through the teleeducation system and the remote distance learning to provide those kinds of classes. We've got a young man who's going through medical school right now. His mother works for us and his father's on our board. And he's in a DO program in Kansas right now. But he has shared with me, he really struggled in his first couple of years because he didn't get the basics when he was in high school. So I think we need to put more resources in the secondary levels as well. And then the last point I would make is for rural hospitals and rural clinics, it's about the culture. Tom said it, Jeannie said it. We're all tight-knit communities. So about half of the providers that work at our hospital are nurse practitioners or physician assistants. Most of them have come from this community. They went to high school here, they got their initial training, maybe as a CNA here. And then we encourage them to get additional training and come back. I think that's one of the strengths that we have in rural is you have these supportive communities that help get folks turned on to a career. They realize they can live and work in a community that they love, and they can make a decent living doing it. And we've been pretty successful doing that for all types of professionals.
Kevin, what do you think is the future for rural hospitals? Where we are with current pay rates, with the legislation that just passed, and what do you need to get done to try to fix the path?
Yeah, that's a struggle, and it's a really dire future. I think that we are going to see a number of rural hospitals close across the country. I think it will be, as Tom was saying, the FQHCs get a certain kind of a wraparound grant that helps to cover those fixed costs. Critical access hospitals were intended to get that through the cost-based reimbursement, but it's just not working like it should because medicine has changed since cost-based reimbursement was instituted. And so I think we need to take a look at the entire way we reimburse rural hospitals. We have to put more pressure on the commercial payers. I mentioned that previously. In studies that we've looked at in Colorado, in the metro areas, hospitals are paid at a rate of approximately 240% of Medicare. In the rural hospitals on the Eastern Plains, we're paid on an average of 139% of Medicare.
Why would that be? Is it because there's you either take it or tough? Is that the kind of
it's a market imbalance. I can call a large insurance company and say, hey, we need to do something about my rates. And it takes them a while to get back to me. If I'm a big system in the city and I own 15 hospitals, that's a very different conversation. And so trying to balance that market strength and give rural hospitals to at least cover our costs. There's a study out there right now that suggests that it's not Medicare or Medicaid that's failing rural hospitals. We essentially break even on those. It's the lack of reimbursement from the commercial payers. But we also have to look at doing things differently. We can't just expect to continue to provide care. And I love Tom and Jean's comments about telemedicine and figuring out different ways to make care available virtually and try to reduce that cost. But you are never going to replace the in-person care. That needs to be there, but we can certainly supplement it with changes in technology and help to extend that care and make it more affordable.
What do you see as the trends over the next 5 years, 5 to 10 years in terms of, we've seen telehealth really come on. We've seen mobile units be used in some communities. And from that mobile unit, they can do telehealth right back to for instance, in a small town in Indiana, they can hook up to Methodist Hospital in Indianapolis or something like that. What do you see as some of the big trends that we'll be looking at, do you think?
I think AI is going to play a role that none of us can imagine right now. And whether that's assisting nurse practitioners and physicians' assistants to maybe there's not a physician available to consult with, and maybe there will be AI to help with that. I think there's technology out there that we haven't dreamed of. I had an opportunity one time to speak with a physician from the Department of Defense, and he was talking about what DoD does. in terms of remote surgeries. I think those kinds of technologies we can look at for rural hospitals and help them. But that takes investment. And one of the other big points I want to make sure to make is what we need in rural as much as anything is capital and access to capital. You're all familiar with the Hill-Burton Act. Well, the last money from the Hill-Burton Act was spent in the 1980s. We need to reinvest. I love my hospital. It's a beautiful place. I have a physician that regular comes by to see me and he says, you know, this hospital sucks, but you guys give great care. So he's differentiating between the building, which is days falling apart, and the care we provide.
That's
So
like my
give us-
Chevy Caprice still is running and is on 417,000 miles, right?
That's about the mileage we have, but let's invest in rural. Let's make a commitment to say we need to have that access to care, and don't just build hospitals for the 1980s. Let's build hospitals for the 2050s and make sure we have that technology available to folks in rural communities.
Yeah. Gene, as you look at your beautiful state in the next 5 to 10 years, what do you think is going to be the movers in medical care and how things are going to change as you look forward?
Yeah, so I do want to come back to this topic of what the future looks like, but you know, I'm not sure if I'm the oldest person on the panel, but I'll pretend to be for a second. Back when I was in college, I worked for the state of Maine on what was the most urgent problem in the state at the time, which is a nursing shortage. Have things changed? No. When I was in graduate school, I worked at the University of North Carolina Rural Health Research Program, which just did the study about rural hospital closures under the One Big Beautiful Bill Act. I worked on a rural hospital closure study several decades ago. Some things have not changed, but a few things have, and I just want to point them out as well. One is the consolidation of the healthcare system. Once upon a time, we really had community hospitals, community providers, physicians who put up their shingle, who are able to practice independently. That's kind of a thing of the past. And I think there's some downstream consequences of that, which are really negative for rural areas. I just don't think there's the same community commitment from the organizations that gobble up our rural providers that there used to be from community-based providers. I also need to say, going forward, that the demonization of immigrants is a problem for healthcare. 1/4 of our physicians in this country are foreign medical graduates because our medical schools don't produce enough. And where do those providers come? They often begin in rural America. In fact, the author Abraham Verghese, I think I'm saying his name right. For anybody who's read Covenant of Water, he's a famous author. He grew up in Ethiopia, went to India for medical school, came to rural America as a physician and developed a life here. Like, we know that in many of our rural communities, they not only welcome legal immigrants, but thrive on the communities that come there. I mean, here in Maine, 150, 200 years ago was the French Canadians. French people came. Now we see a lot of people from Central Africa. Lingala is a new language here in Portland, Maine that people are learning. And a lot of our CNAs and frontline healthcare workers are increasingly people who are legally immigrating here. But the demonization of immigrants in this country is going to have a very strong chilling effect on our healthcare system that I think will disproportionately affect rural America.
Tom, what do you see? What do you see in the next 5 to 10 years for family physicians? Will most all of them be in FQHCs or in medical groups as opposed to being independent? Is it the paperwork that's overwhelming, all of those kind of things? How do you see it moving forward?
Well, I think there's some reason to be optimistic. I think the message that I and a number of my colleagues have been trying to communicate is that the attraction of primary care, of family medicine in particular, is the chance to really know your patient and to work with them over a period of time and to try to design care that really fits their needs and their biases and their um, eccentricities. Um, and and in other words, I've gone so far as to say, if you want to be a physician, this is where you belong. If you want to be a technician, then you should go into one of the specialties, because they have become so technically oriented that they in so many uh, of the of the specialties, they really never have a chance to get to know their patients. And in fact, most young people come to medical school really wanting to know and serve people. And so I think the best way to do that is through primary care. Now, what we need to do is develop payment structures that will support that, and that has been a challenge. I I, uh, I think one of the things that troubles me a lot is I see hospitals closing, or hear of hospitals closing, simply because, or not simply, but the main reason being given is they weren't profitable. And rural hospitals have no chance of being profitable. They have to deal with a very broad range of services uh, with relatively small numbers, and so I think that they need to be supported. And I see their services very much the same as the services of the fire department. This is a vital service that we need to support. And we have, our current system does not recognize that.
Yeah, what does this is for all of you, what happens to a rural community if they lose their hospital, if they lose their doctor? These rural communities, what I always saw is the heartbeats were like the doctors, the hospitals, the schools. Those are the churches, those are the places where everyone comes together. Right. And as I said, in my home state, over a third of our counties now, no OBGYN services. What happens then to a county that's in that kind of situation? It can't bode well for growth in the future there.
There was I'm sorry, Tom, go ahead.
It clearly has a very negative impact on the economic future of that community, but just the sense of well-being that comes. Rural hospitals are kind of organizing centers around a lot of other health services, whether it be emergency services or social services or rehabilitation services or infusion services. There are a lot of things that are available through the small rural hospitals. And we've talked about telehealth, and I'm obviously a major supporter. But I don't want to give the impression that that can replace the human beings that need to be at the core of these facilities. The telehealth is an amazing and beneficial tool to use, but it does not, and I will not, become that our patients don't want to be treated by robots, I don't think.
Kevin?
I agree with you, and I would add, there was a study done by the Kansas City Federal Reserve Bank on what happens to communities when their rural hospital closes. And one of the most significant things they found in the study, I thought, was the job losses continue for many years after the hospital closes.
Yep.
It starts out with the big bolus of job losses because the hospital, and then the school starts to close, and then the restaurants and the little shops in town start to close. And they showed a trend where those job losses can go on for 5 to 10 years. I want to also get back to a point that Jeannie made about the systemization of rural hospitals. I think that there's a trend right now where we're encouraging rural hospitals to join systems. I think sometimes the hidden threat to that is essential services like Tom was talking about, oncology, OB, those services that could be bundled together in an urban area and be more profitable for the system are also often removed out of the community. So I'm a big fan of the community hospital that cares, the independent community hospital that cares about its community, is making decisions that's in the best interest of its community. But the economics are a real struggle. And I love the idea of this is like a utility. There's a cost of doing business. There's a capital investment that has to be made. And you have to continue to make some margin in order to reinvest in the technology. Otherwise, you soon die. So it's reimagining the entire system.
Yeah, nobody is demanding that the fire department hit a certain profit number.
That's correct.
And they're not trying to figure out ways to have less parts of the community served. I've heard occasionally here and there about like private fire models, and I couldn't think of a worse thing. And it's like, oh, you're not going to help this one, but you're going to help this one. It's the communities in together on these kind of things. Do you engage with your legislators? Because they obviously at some point make the decision, funding, no funding, funding for this, no funding for that. Do you find it important to engage with your legislators? Kevin, I'll start off with you.
Yeah, I spent a lot of time in Denver. Next week, I'm going to DC. I'm in regular contact with our congressional delegation and state legislators. And the thing that's very frustrating, I'm always welcome in their office. They're always sympathetic.
They will love you when you're there.
That's right. But it's tough and to pry the money out and say, this is really convincing people that we need to re-engineer the healthcare delivery system. There's a lot of fear in trying to do that. And so status quo wins. Okay, we'll try to get you a little more money, or there's a new program that's bolted on. We sort of talked earlier about this patchwork of revenue that rural hospitals have to put together, and rural physicians, in order to stay afloat. And it really seems to me to be much simpler if we just created a single stream of revenue that covered costs and the services that were necessary for each community. And we could simplify a whole bunch of stuff. One quick anecdote about the administrative costs. About 3 or 4 years ago, we had one case manager at our hospital, the person that calls for prior office, et cetera. We have 8 of those people right now.
Wow.
Because the demands of the insurance companies and the other payers to justify the care, review the documentation, show us this report, it's just increased the amount of administrative burden. And I'd love nothing more to get those people back on the floor taking care of patients instead of talking to insurance companies.
Gene, go ahead, Dr. Tom.
I guess I would just wholeheartedly reinforce what Kevin just said. We have to get the resources focused on the actual care and not in moving the money around, which has turned out to be an extremely costly part of the whole system. If we spend 25, 30% of the healthcare dollar on administration, that is not a good deal, but that's what we're doing now. Right.
Do you engage, Dr. Tom, with the South Dakota congressional delegation, with the South Dakota legislature, telling them, hey, look, here we are. Our community is focused on school, church, fire, police, hospital, medical, and you blow a hole in any of those, you basically start the decline of the town.
Oh, absolutely. We certainly continually try to communicate that. Most of the time they think we just want more money, and I have tried to say we want a system that's more efficient and more focused on the improving the quality and availability of the product, rather than just putting more money into what is basically a dysfunctional structure.
One thing I
Yeah.
Go
So
ahead.
if I could
Go
just
ahead.
add though, one thing that I think is something we all should acknowledge is that states can only do so much. There's, most of the money for our healthcare system is coming from the federal government. State is secondary, private insurance is somewhere in there. And when we're looking at, $1 trillion over the next decade being withdrawn from federal spending, I think is significant. I heard Governor Sununu from New Hampshire recently say that while the federal government does run Medicare, it could find waste, fraud, and abuse in Medicare. It mostly shifted the burden of finding cost savings to states through reduced provider taxes, other changes. And I'm meeting with my main team to try to figure out what we do for the coming years, and it's challenging. And I would say I appreciate the fact that our Senator Susan Collins, argued for a rural health transformation fund. There was $50 billion ultimately included in the bill against the $1 trillion worth of withdrawal of federal funding. But just to put that into context, half of it goes to all states, including rural urban states. The other half can be allotted to only 13 states. It begins this year, but ends in 5 years before some of the deepest cuts take place. And nothing in it guarantees that the funding goes to rural hospitals. I worked with a colleague and we went through it, and you could indeed, if you were trying to appease, the Secretary's current views, you could come up with uses that are for getting rid of pesticides in agriculture because it's gonna, improve prevention. You could promote consumer-facing technology like the apps that promote supplemental health services that does nothing for rural hospitals. And you could provide technical assistance for organizations to improve efficiency and create a state-based DOGE. So I just need to say there's work to be done on what has great promise for states, which is a rural health transformation plan due in December. There's funding for it. I think we all have an obligation to figure out what states can and should do with that funding, but it will take some work in the coming, months, because we are on a precipice of major changes that are probably existential for many of our rural communities.
I think they are existential. I think we're going to lose many rural hospitals. And as we've been mentioning, when we do, we start to lose the community as well. For each of you, we've only got a few more minutes. If each of you would take a minute or two and just tell me what would you like to see the most in the next year or two that would make things better? I will start with you, Jean, since we are blessed with you right now.
Well, thank you so much. I appreciate that. I wish we could find more common ground. I appreciate this conference, this summit, the people who speak at it, because I do think it represents that spirit of community and caring about each other, about our neighbors, that is at the heart of rural health, but also our healthcare system. We need to work harder to find it. I think there's been a lot of demonization of people ripping off Medicaid to try to get Medicaid fraudulently. I don't think that's really true. I think there's views that the Affordable Care Act, which has covered 2.8 million people in rural America, we shouldn't forget that this fall, people in rural areas who get Affordable Care Act premium tax credits are going to lose a significant amount, significantly more than urban areas, because of the lack of inclusion of this extender in the tax cut bill. That's going to be significant. So I just hope that we come out of this period with a renewed sense of community that oftentimes generates from rural areas, but spreads nationwide.
Thank you. Dr. Tom?
I take a minute. Just one of the things that came up earlier was the concern about obstetrical care. And I think that is a serious, serious concern. I know Kevin has mentioned that their hospital had to give it up. Our hospital had to give it up. But we're seeing larger and larger areas where immediate access to obstetrical care is simply not available. And that's reflected in the fact that our maternal mortality rate has gone way up, and it's now one of the worst rates in all of the wealthy countries. And some of that is just simply the maternal deaths related to childbirth have been studied and found that about 70% of them are preventable if people have access to care, but we're actually reducing. I realize that's not the question you asked, but
No. Well, when you mention that, so how do you raise a family in an area where you can't get obstetrical, OBGYN services?
yeah, it will have a big impact on, like we talked about, economic development. Young families are not going to come to a place where they're not going to get adequate protection from these really very basic services. So and it's a complex issue. It's partly related to finances, but it's also related to the availability of personnel. How do you deliver a complicated service with very small numbers? That was what we encountered, and so it's a complicated issue, but it's a desperately important issue.
So Dr. Tom, let me just ask you this. So when a woman is expecting a child, do they sometimes like move next door to or move to the area where the services will be available, as opposed to where they currently live, where there are no services?
Well,
for a
can
couple
happen. I don't know.
Or a couple of weeks or whatever.
It actually, we were in Cuba a number of years ago, and Cuba does that. They have maternity homes where women come when they're late in their pregnancies, and they just stay there, and they have pretty good outcomes. But that's off the topic a bit. But in answer to the question, I did not see that happen very often. But it certainly is something that is a consideration.
Kevin, what would you like to see in the next 2-3 years to make it so that people can recognize the importance, that people can recognize this is as critical as any other service we have in our state, in our country?
Yeah, thank you for that. I'm driven by a couple of different things. One, I have a firm belief that rural communities are absolutely essential to the national security of our country.
Yeah.
Rural communities produce most of our energy. They produce our food. They produce the fiber that we wear. They produce the clean water that we all drink. And if we allow those rural communities to deteriorate, where there's nobody there to grow food, produce energy, make sure the water's clean, then we're going to be in trouble as a nation. I'm also driven by the philosophy that where you live shouldn't determine if you live. And I'm struck by the disparity already. There's something called the rural penalty, where life expectancy in rural areas for working age men is much lower than what it is in urban areas. Why is that? And I would suggest that it's access to care. You just had a really interesting conversation with Dr. Dean about OB services. What we see in our community is most of our moms that are delivering babies, their labor is induced, or they receive a C-section because it's done at the schedule of the doctor. When can you get to town? Let's induce your labor, and we'll deliver your baby that way. And I'm no clinician. I'll defer to Dr. Dean and Jean, but it seems to me that's not optimal care. So how do we figure that out? So I would like to see us identify what essential services do rural communities need to have, and let's figure out what that costs, and let's make the appropriate investment. And I would suggest that's not a lot of money. I can do things much simpler in my little hospital than maybe what happens in the city, and I can do it just as effectively. So I think you invest a proportionally smaller amount of money in rural, the return is going to be much greater, and we're going to see that rural mortality penalty start to reverse, and we'll see more productivity come out of our rural communities.
One of the things, when I was asked, why did I vote for the Affordable Care Act? It was not easy to vote for it in some states where, some of the public opinion was the other way. Now it's overwhelmingly in favor of it. But at the time of the vote, it wasn't. And I said, well, it's one of the reasons it primarily came down to was the example of, so you have two people living in the same town, a little bit apart from each other. You have a child in the red house with a single mom who's trying to make ends meet. And that child has type 1 diabetes. And you have a child in the wealthiest part of town with, the most successful financial parents in the world, and that child has type 1 diabetes. Well, God loves both of those children equally. And they're both equally entitled to get the same high quality care. One child isn't more important than the other. We love them both. They're both members of our community, and their success will be our success. And I said, if we can't do that, then what are we doing? And so we provided care for 20 million more Americans. That's what I worry about when we see that up to 11 million may lose care. To Kevin and Dr. Tom and Jean, I want to thank you so much for being part of this. We're really grateful to you for the yeoman-like work that you do every single day. If I drive out to Denver from Indiana on I-70, I'm going to stop by and have lunch at your hospital with you. And to thank all of you viewing at home for joining us today. This has been a terrific start to the Rural Progress Summit. We'll be back tomorrow at noon with more great speakers and panels, including conversations with Representative Chrissy Houlihan, CEO Carly McManus about the benefits of paid family and medical leave. The team at Impact Social will share their insights on the economic outlook in rural America. We'll provide some analysis on the negative impacts of the so-called Big Beautiful Bill in terms of what it will do to rural America. Governor Andy Beshear of Kentucky will address the summit to share how he lives his values as a progressive leading a deep red state. Filmmaker Audra Mulkern will join us to discuss our project, Women's Work, the untold story of America's female farmers. Tribal leaders will share their success and struggles to care for their communities. And Senator Martin Heinrich and Representative Gabe Vasquez will tell us about the ongoing threats to public lands. For our audience on Zoom, the virtual lobby will remain open throughout the summit, so please visit our partners at their booths. The Rural Progress Summit would not be possible without their support. For our viewers on YouTube, please register for the summit to join the conversation in the Zoom room, or come see to all of you, Dr. Tom, Jean, and Kevin. 15 years ago, or maybe 25 years ago, we wouldn't have known what the Zoom room was. That's how technology can change, and we hope improves healthcare. For our viewers on YouTube, please register for the summit to join the conversation in the Zoom room, or come back to our channel tomorrow to follow all our great discussions. And if you like what you heard here today, please subscribe to our podcast, The Hot Dish, on Apple Podcasts or wherever you get your podcasts. We have deep dives, thoughtful conversations, and a good bit of fun every 2 weeks on The Hot Dish. Thanks for joining us today. Thanks to all of our amazing guests, and we'll see you tomorrow.